Urogynecology and Pelvic Reconstructive Surgery here at Hackensack. He graduated from the Shahid Beheshti University of Medical Sciences in Tehran, and then completed his residency in OBGYN at Case Western Reserve in Cleveland. He's board certified in female pelvic medicine and reconstructive surgery, and also has his focus practice certification in minimally invasive gynecologic surgery. He's going to speak to us today about pelvic floor dysfunction. So thank you, Dr. Shakiba, for coming and speaking to us, and welcome.
Good morning, everyone. Okay, got it. I don't know if you have my screen right now. Or...
We don't. We only see you, but we don't see your screen.
You have the full screen, right?
Yes. Mm-hmm.
Good morning, everyone. I'm Dr. Shakiba. It's a real pleasure to presenting my topic today, which is called pelvic floor dysfunction and elephant in the dark room. I thank you, Hackensack Department of OBGYN for inviting me. The topic is a very big topic and basically covering a wide range of issues here. And the reason I choose this title, An Elephant in the Dark Room, is because as you guys know me, you folks know me, I've been practicing urogynecology for the past 14 years in Hackensack, and I divide my these 14 years to 7 different years. The first 7 years, I will call it, I was kind of in the dark room, and second 7 year was a big transition for me. Obviously, it started back in 2016. And I just want to share this very interesting experience from my view regarding pelvic floor dysfunction and everything in the pelvic area. I have to say I see a significant satisfaction on the outcome with this new view with my patient, and the goal is to share this with you. I hope you find it useful. I'm looking forward for your feedback on this. Pelvic floor dysfunction or pelvic floor disorder. First of all, pelvic floor refers to a group of muscle and tissue that support the organ. Obviously, there is a couple of organs in the pelvic area which all know about it. Is uterus, rectum, and bladder and bowel are the major one. Also, we should call pelvic floor muscle itself and pelvic nerve the other one. So all of the above, if you have any dysfunction, we should call any related situation with the dysfunction of above organ a pelvic floor dysfunction. Obviously, voiding, defecation, menstruation, conception, and sex are major function of pelvic organ, which will be affected by pelvic floor dysfunction. If pelvic nerve are affected, it will cause pelvic pain. If it's pelvic muscle and ligament are affected, we'll call it pelvic organ prolapse. It is highly prevalent, affect both men and women, but is much more common in women. Based on different survey, 25 to 50% of women are affected by one or more pelvic floor disorder. And obviously, the study also revealed the frequency of PFD increase with age. The objective of this presentation, I divided it also to 2 different parts. One is the before turning the room light and after turning the room light, which I will tell you why. So before turning the room light, we want to find out why PFD is so common, why is more common in women, what are the unknown about different pelvic organ disorder, and why are there so many unknown, what piece of puzzle is missing. After turning the room light, the goal is to understand why PFD often involve multiple organs at the same time, and understanding the complex physiopathology or pathophysiology of PFD. And also evaluation and management of patient with pelvic floor dysfunction would be the goal, the way I do it now. And also I try to share the story of one of my patients to show you how I do manage it these days. Now, the question is, the first question is why pelvic floor is so common in men and women. What's made pelvic area so vulnerable? The key here is that pelvic area is very rich in rich in nerve and very have a complex neuroanatomy and musculoskeletal structure. And believe it or not, I mean, pelvic area, the fact is one of the only area in our body that have some semi-autonomy from brain. The witness of that is, as an example, if you look at parasympathetic nerve system, you will see the only area in your body that preganglionic nuclei of parasympathetic located. Everywhere else is located in the brainstem, but for the control of pelvic floor, everything is located in the pelvic itself, which is at S2, S3, and S4. That shows the semi-autonomy that pelvic area has. The difference with the brain, though, is brain is well protected with bony structure of a skull, whereas woman pelvis, or in general pelvis, is just protected from trivae, and the cephalad portion of pelvis is wide open and could underwent. And the other big difference is the gravity, which is compressing the pelvic area constantly. As you can see, so presence of any mass like pregnancy or tumor could directly affect pelvic. Why is more common in women? There were many reasons. Obviously, there is a more risk of exposure to infection given the access that woman pelvic has to the outside world, and ascending infection or germ could travel to tube and finalize land in the pelvic area. Also, women menstruate, men won't menstruate, obviously, and for any type of stress or distress, the cervix could become stenotic, given its different nerve function of having alpha-1 receptor, could lead to stenotic or tightness of cervix, result in retrograde menstruation, that by itself could lead to inflammatory change and disease called known as endometriosis. Now, why only some patients get endometriosis and others don't is a subject of different topic, which we don't have time to go over it at this point, but menstruation is definitely another risk factor here. Also, pregnancy is exclusive to women, and obviously childbirth is also exclusive to women, and all, regardless of type of childbirth, either C-section or vaginal or instrumental delivery, all of the above could cause bleeding and hemorrhage and fibrosis and inflammation in the pelvic area more than men. And last but not least is the procedure and instrumentation in the pelvic floor of women are much more common. Procedure like DNC, hysteroscopy, IUD insertion, obviously increase the risk of ascending inflammation. Okay, now one common feature of pelvic floor disorder is the following. It involves a wide range of spectrum as young as 10 and beyond. Patients' symptoms are usually not isolated and consist of multiple pelvic organs related symptoms. And the other interesting feature that I noted is patients usually are referred to many specialists and subspecialists, you name it, urologists, gynecologists, GI, pain management, PT, and so on and so forth. And also there is usually no clear answer to patient to explain all of the related symptoms. Despite of significant progress in understanding PFD in the past century, there are still many aspects of this condition that remain unknown, and the cause and mechanism behind most pelvic floor dysfunction are still poorly understood, leaving them in a state of obscurity. Now, how is our current management of pelvic pathology these days? I categorize the pathology in pelvic organs or pelvic floor to two big categories. One that we call it well-known pathology, and second is not so well-known pathology. What do I mean by that? Well-known pathology are the group that we know well, the etiology, pathophysiology, risk factors, how to prevent it, and how to treat it. A good example is cervical cancer, PID, ectopic pregnancy. I will pick one of them. For example, for cervical cancer, now we do well know the role of HPV and why having multiple sexual partner and unprotected sex could lead to increased risk of cervical cancer. We have a good protocol in place. And since we know the HPV, the risk of cervical cancers decreased significantly, and we're doing really well on the management of cervical cancer. Same for PID. We do know what kind of germ could lead to STD and could risk the PID. And we have pretty good management and antibiotic on place, and usually patient get 100% cure from it. Now, the second category are not well-known pathologies, which we don't know what is the exact cause. We don't know what is the exact pathophysiology. We don't know how to prevent them. We don't know, and we often have many theories and controversy about all of the above. There is usually no definite cure, and our treatment plan are based on expert opinion. So the list is long, as kind of embarrassing, but as you see, overactive bladder, IC, IBS, pelvic organ prolapse, chronic constipation, fecal urgency, fecal incontinence, recurrent UTI with negative urine culture, genital arousal dysfunction, vulvodynia, sexual disorder, and vaginismus is only the famous one. Also, I take another step further. Even this so-called GYN pathology as also could be, to my new way of looking at it, I would still call them pelvic floor dysfunction or disorder. A condition like PCOS, endometriosis, unexplained infertility, hyperemesis, gravidarum, and recurrent pregnancy loss. And even if my obstetrician friend don't think I'm stepping on their shoes, even preeclampsia may have such a role, be placed in such a category. Now let's start with a couple of them as an example and to see how do we manage them. So let's start with IBS, or irritable bowel syndrome. IBS is a gastrointestinal disorder characterized by chronic abdominal pain and altered bowel habit in the absence of any organic cause. Pay attention to this. In absence of any organic cause. So the traditional and very common feature is that patient come to us with some menstrual disorder, and they also complain of constipation or diarrhea or pain. In bloating, what we do typically, we just say, all right, go see the GI. And guess what? It is most commonly diagnosed gastrointestinal condition and account for approximately 30% of all referral to GI. So, and the pathophysiology of IBS remain uncertain. So basically, we're creating a big name here and telling the patient that account for 30% of our GI referral. We're just telling them, instead of saying we don't know what's going on, we just say you have IBS. So obviously, it falls on that category, doesn't have the cause. We don't know pathophysiology. We have some idea. We don't know how to prevent it, but there's many controversy. The next champion on the list is IC. Same thing. Patient this time come with bladder issue, urgency, pain with urination. What do? We just say, all right, go see urologist. And same story is typical of unknown here. IC is or chronic bladder pain in the absence of an identifiable etiology has historically been called IC. This term is misnomer since there is no clear evidence of inflammation really, and also and the condition is reliably associated with any anomaly in the interstitium of bladder. So the better way to call it would be probably bladder pain syndrome, as many experts suggest. But by definition, patient has this unpleasant sensation with the bladder function, and little is known about the etiology and pathology of interstitial cystitis. Again, the management, as I said, is the same. We basically have some medication like Elmiron and bladder instillation, and none of them really work. And so we have no idea what's the exact cause, exact pathophysiology, and how to prevent it. And again, we have many theory and opinion how to manage it. Now let's just talk about something that we deal with. We talked about urology referral and GI referral, but even endometriosis is approximately 10% of our patient women population in reproductive age globally are affected, maybe more. And we all know what is endometriosis is the result of ectopic endometrial implant growth and elicit an inflammatory process outside the uterine cavity. I just said we all know, but we all also know that no one agree what is the exact cause of that, and why someone gets endometriosis and other one don't. There is many theory and disagreement about it. So this is retrograde menstruation that could lead to menstrual to endometriosis. But I know myself many experts on endometriosis that if you tell them the endometriosis is caused by retrograde menstruation, they get really angry about it. So there is a lot of unknown, and we need to find out what's happening. There are some genetic factor, there are some impaired immune system or stress, excessive retrograde flow, obstruction, cervical stenosis, hormonal imbalance, and autonomic nervous system imbalance could be influencing endometriosis, in my opinion. But it's suffering from all of the above again. We don't know the cause, we don't know pathophysiology, and so on and so forth. The list goes on. With Vulvodynia, same story. 3 to 15% of women have it. I don't have time really to read all this slide, but everybody knows what's our deal with Vulvodynia. We don't exactly know what is causing it. We don't know how to really manage it. Now let's step in the shoes of our obstetrician here. Even hyperemesis gravidarum, as I said, I would categorize it in this because it's related to the pelvic cavity as well. And we know that we still don't know what causes hyperemesis gravidarum and how to manage it, what's the etiology. We have many theory behind it, but we don't know exact cause. Same for polycystic ovarian syndrome, which account for between 6 to 10% of reproductive age women are affected. Do we have a consensus about the etiology? No. Do we have any Do we have many unproven theory? Yes, like genetic, obesity, insulin resistance, and etc. How about recurrent pregnancy loss? We have almost up to 50%, 50%, I mean half of patients with recurrent pregnancy loss have no clearly defined etiology. So we still have no idea about half of the case why it's happening. So all it account for all the mentioned pathology. The list goes on. As I said, because of lack of time, I can't go one by one. But now I just want to share a story of one of the patients at this point to see how miserable and how complicated the patient with PFD could be. This is a 39-year-old gravida for para-0. She previously had 3 first trimester miscarriage. This is actually my own patient, and I will show you the procedure performed on her later. So 3 prior first trimester miscarriage presented with severe pelvic pain with intensity of 8 to 9 out of 10. She really couldn't even walk with the level of pain. Although patient always was suffering from pelvic pain, but the pain was getting worse after performing the DNC, which was done for termination of pregnancy at 12 weeks gestation, secondary to severe intolerable hyperemesis. So the nature of pain is burning, traveling to vestibular area and external genitalia. She has severe dyspareunia, and pain is worse with sitting. GYN history, age menarche at 12, and she always had painful and heavy period. And she was placed on OCP by her gynecologist, which was initially helpful, but gradually become ineffective. No STD and no abnormal pap smear. And look at the past medical history that she put in the chart. Very, very typical of patient coming to my office with PFD. They all have IBS, interstitial cystitis, and guess what? Anxiety and depression. So I wonder, having all of the above symptoms for many, many years would cause anxiety and depression, or depression cause that. So it's kind of chicken and egg story. So hard to say. Patient also, since it's been in my office, I usually ask about urology question and GI related question. And guess what? She also have complaint of urinary urgency, frequently difficulty emptying her bladder, nocturia 3 to 4 times per night. And she received many course of antibiotic for recurrent UTI in the past, which helped her symptom for short time, but symptom recurred again right away. Urine culture was often negative. She was referred to urologist, and cystoscopy was negative. However, she was told she had IC. She previously received Elmiron bladder installation without relief. A course of even vesicare was failed to improve her symptoms. So someone at her age was receiving vesicare without having any kids before. Patient had also a history of constipation and underwent, as expected, a GI referral, and she underwent colonoscopy, which was negative. Very, again, typical of these patients' story. And of course, she was diagnosed with IBS. Patient was then also referred to psych, and because nobody knew what's going on, and patient herself usually think maybe she's crazy, or others think that she's crazy, because how in the world you can have all the bad things? How can you have urinary problem at the same time of menstrual problem, at the same time of having GI issue? So maybe you are crazy. That's the answer. And of course, she was also referred to psych, and she was diagnosed with anxiety and depression. So this is past surgical history. We're going to come back to this lady a little later, but I just want to show you the example and clear example of typical patient with PFD, how miserable and hopeless they can become. But what are we missing? That's why I use this idiom of elephant in the dark room, which is a little different than when you say in English, elephant in the room. It usually elephant in the room refer to a big topic or which is taboo. Everybody know about it, but no one want to talk about it. Elephant in the dark room, however, is an idiom about religious tolerance or intolerance. The name of idiom is taken from traditional Persian story as told by Sufi mystic Rumi, which several men were tasked with identifying an animal by jutting their hands into a darkened room to feel rather than seeing the animal as a whole. Each identify a piece of the elephant accurately from their perspective, and then but all failed to recognize the whole. The elephant here obviously symbolized the god in Rumi's story, and basically was saying that, yeah, all of these guys were fighting about what they felt because there was no light in the room. And if there was, they could see the God is only one, and they are just fighting about different perspective and religion for no reason, just because lack of having a lack of whole picture. The moral of the story is that if there was a light in the room, they could all come to the consensus and the disagreement. So this is an example of one of my patients.
To take it seriously enough to want to address it as an ongoing condition. And when I came here, I heard the term endometriosis for the first time. I have seen 2 urologists, 3 urogynecologists, like a lot of gynecologists. Initially, I was just told I had UTIs. I've been given antibiotics regularly. I was told that I had interstitial cystitis at one point, and I was told that I just had a lot of stress. My most excruciating symptoms are burning when with urination and frequency to go to the bathroom. Other symptoms I have are excruciating sex and pelvic pain. When flares are really bad, I pretty much just stay in the bathroom for hours at a time. Sometimes it's hard to stand up. Sometimes I feel like I'm losing control of my ability to decide if I'm going to the bathroom or not. So I'll stand in the shower for hours. So I got surgery in April of this year. A few days after the surgery was the first time that I peed without any burning sensation in years. And I went a few months without any flare, which hasn't happened in a really long time. And even the flare that I did get felt mild, extremely mild. Now that I have less pain on a day-to-day basis, I'm really motivated to learn more about what's happening, to find a community and to try to treat it.
Okay, so let's go to the next slide. So this is a clear example of, I'm trying to go to the next slide. So a clear example of patient PFD, that was not the patient I explained the story, that was a different patient, but I just want to show you how many doctor and they have to see, and they get lost in between doctor, and maybe the cause is the lack of light in the pelvic floor dark room. And now let's turn on the light in the pelvic dark room, since some of our audience getting impatient. So what is the suspect cause here? The suspect cause should have the following characteristic. It should be something that connects multiple organs. It should be something that has not been studied well and is not well known. And also, it should be something that is delicate and vulnerable. So pelvic nerve maybe meet all of the above criteria. So So first thing is, do we know pelvic nerve very well? Did we study pelvic nerve very well? I have to say, I'm speaking of myself. During my entire training, really, our education and teaching about pelvic nerve was very, very limited. And also when I look at the data and study, I have a feeling we are more focused on hormone management when we go to study different pathology, and we are all focused on hormone. And obviously, recently, there are more and more work done on the nerve as well. But the pelvic nerve definitely is an underserved area. So do we have the multi-organ reach? Yes, we do. Actually, is clearly the multi-organ reach. Or the nerve, if you see the anatomy of pelvic nerve, you can see there is, I don't know if you see my cursor here, the pelvic nerve, to me, make it very brief, the introduction. As you know, any nerve come from two categories of somatic nerve and autonomic nerve. The autonomic nerve are sympathetic and parasympathetic. And this nerve is right on the superior hypogastric plexus here on the sacral promontory, which divide to two big nerve and right and left hypogastric plexus hypogastric nerve, which then it become branched to three different areas. And this branching here is called inferior hypogastric plexus. So this is mostly the sympathetic nourishment or pelvic nerve distribution. Parasympathetic nerve, however, come from a little deeper area. It's called S2, S3, and S4, and join this plexus via the sacral splanchnic nerve. They're a little deeper and better protected. The other nerve are somatic nerve, which in our discussion today, what's more important are the afferent sensory nerve of the pelvis. They all run actually alongside of this sympathetic nerve or this parasympathetic nerve, and the trajectory of all of the afferent nerve and sensory nerve is actually the same. And some of them obviously travel with the pudendal nerve as well. So as you see, I'm using this example. If there is a light bulb that is flickering and buzzing, what is your first step on the management of it? Is most likely everybody going to do changing the light bulb, right? Now, what do you do if there is two light bulbs at the same time in the room flickering or buzzing? So what we do, maybe we're going to change both of them and to see what happens. It's so easy to do. But if you change it and it's still buzzing and flickering, then you're probably going to go and check the electrical panel. And if there is no problem there, then what is the next step is to look at this wire. So the wire connection between the wall might be the problem, which is exactly the case in the pelvic area. And why pelvic nerves are vulnerable? The autonomic nerve and afferent pelvic nerve, as I showed you before, are a very thin and unmyelinated small fiber. They are usually C fiber or A delta fiber, which are very fine nerves, so therefore are more vulnerable. Also, the autonomic and afferent pelvic nerve are mostly traveling very superficially under the peritoneum. Here, I'm going to show you one of my surgery. This is the sacrocolpopexy procedure. However, it's clearly showing the trajectory of hypogastric nerve here. That's why I picked this video. So you can see the trajectory of hypogastric nerve on the right side, which is easily visible by looking at the peritoneum wall. And that's why I said these are traveling very superficially under the peritoneum. So this is superior hypogastric plexus, and that's where the hypogastric nerve divide and go to right and left. Let's move it a little fast, move forward. You see I'm moving the nerve here, and the further, oh, I'm sorry. Let's start this again because we missed the point here. The more we go caudate, you can see the branching of the nerve, and you can see the this right the branching of hypogastric and starting of the plexus formation here. And one branch go to the bladder, one go to the urogenital area, and the third one go to the rectal area. And this is the left hypogastric nerve here on the sacral promontory. Okay, so what is the suspect? Pelvic nerve have all the following criteria we mentioned. It connects multiple organs at the same time. Pelvic nerve has not been studied well and are not well known, and pelvic nerves are delicate and vulnerable. How is the nerve damage could lead to multi-organ symptom? So what's the pathophysiology here? The neuroinflammation leading to a small fiber polyneuropathy of the pelvis. And so there is two things happening here. One is the inflammation that affect the pelvic area would lead to neuroinflammation, and it lead to what I call small fiber polyneuropathy of the pelvis. So the damage of the inflammatory change and the insult on this superficially traveling nerve would by itself create a neuropathy in the pelvic area. And secondly, this by nature, the pelvic area are well connected and have many crossing effects on each other and convergence and referral to each other, which is why pelvic organs are all affected at the same time because they receive the referral from each other. Now, let's take the endometriosis as an example because it's the easiest one to be understand here and find out the cascade of the event. Here, as you see, the retrograde menstruation happened, and for difficulty of immune system to get rid of the blood and endometrial tissue for any reason, this implantation happened. So once as I said, because of impaired immune system, implantation of ectopic endometrium happened, and the inflammation process starts. And we have mast cell tissue that are designed to stay in the soft tissue of the pelvic area and bowel and others of the. So mast cells are not circulating in the blood, and are usually staying in the soft tissue for defense purpose. But the problem is that the activation of the mast cell in this area would lead to secretion of many toxic material with like TNF-alpha, interleukin-1, 6, and so on and so forth. And also mast cell would secrete some histamine and heparin, which also will lead to congestion in the area. Also, this new implant need blood supply and new vascularization, and because of the presence of nerve growth factor, which is secreted by mast cell again, we're going to have additional growth of sensory neuron and nociceptor in the area. So let's take a look at this picture. This is very telling. If you see on the right side of the uterus sacral, right pelvic sidewall, you can clearly see the trajectory of 3 branches of hypogastric nerve in a healthy peritoneum. And on the left side, you can see a very damaged, like a chronic wound sitting there with the endometriotic implant on it. And you can easily see how this mast cell activation and activation of this very severe inflammatory process is directly affecting the underlying nerve there. So if this implant's sitting on the branch that go to the bladder, so guess what? This patient gonna have hypersensitization of those nerves and would lead to urinary urgency. If it's sitting on the nerve that go to the rectum, would cause constipation or urge to have defecation and so on and so on and so forth. So therefore, because all these nerves are right next to each other, inflammatory process can affect all of them, and you can see it in this picture very clearly. The other thing that is very common in our thinking, we always think that when there is a pain, is just because the receptor are the only area that catch the pain, and we're looking for receptors only. I just want to put your attention here to the axon as well. When a localized inflammation was elicited on a nerve, injury to the axon of a sensory cell caused the soma to become hyperexcitable. This manifests as increased action potential discharge to a normalized stimuli. So basically, as you saw on that last picture, when the axon of these nerves are affected by inflammation, is well studied and well proven that neuropathic change will happen, and the action potential of the nerve will be different, and therefore the nerve going to be more hyperexcitable. So as you see in this lady, this is also one of my case. She has no active endometriosis, you can see, but you can clearly see retraction of the sidewall on the left pelvic sidewall, with directly affecting the hypogastric nerve and affecting those axons. And these patients clearly have nocturia, urinary urgency, urinary frequency, and difficulty emptying their bladder, in addition to many other symptoms like pelvic pain, dysmenorrhea, and so on and so forth. Next issue that we have to pay attention to it, as I said, there is many interconnection in the spine between different nerves. As you see here, the afferent nerve or sensory neuron come from the dorsal route and go to the posterior gray horn of the spine. And over there, you can see many interneurons that can connect different nerves together. This could be between visceral organ, and could be between visceral and somatic organ, and could therefore affect multi-organ involvement and referral. I try to show you these are very, very complex topic, and as basically in 1 hour talk, we cannot cover all the detail of it. I try to be as simple as possible. So inflammation processes start, mast cell activation would initiate, and therefore repeated or prolonged activation of nociceptor will take place. And therefore, we're going to have peripheral sensitization, increased expression of existing receptor, and then addition of new receptor to the cell membrane would also happen. And all of this would lead to increase this excitability of nociceptors. And this would cause ongoing nociceptor activation. So therefore, we're going to have afferent bombardment of noxious information into the dorsal horn of the spinal cord. In addition, as I said, with this mast cell activation, it's going to be a direct damage to the axon, which would make the soma of the nerve to become hyperexcitable, and therefore add to the additional afferent bombardment. So these are all would lead to central sensitization and many, many complex vicious cycle now start to kick in. So the first and initial one would be hyperalgesia, which means increased pain to the noxious stimuli. So something that is normally not very painful to average people, going to be painful to these patients. If that remain untreated, would lead to allodynia, which means pain to a non-noxious stimuli. Something that is not at all painful to average people would be painful to PFD patient. As I said, the viscerosomatic convergence is going to happen, and then which we call it referral pain. Basically, as I show you on the spine, this interneuron would cause referral. So if someone have uterus pain, is going to have a referral to the lower anterior or suprapubic area clearly. And the next thing would happen is viscerosomatic reflex, which the good example of it, I would say, is the vaginismus patient. So patient who's having constant bombardment of afferent noxious information would have a contraction of somatic pelvic muscle in reflex. And that's why these patients always have a very tight levator muscle. So the tight levator muscle is a result of those nerve stimulation and hypersensitivation. They are not the cause themselves, they are the result. So sending them to physical therapy is a good thing, but as long as we know how to address those irritated nerve as well. Lastly, there is a visceral cross-sensitization, which is another reason why this multi-organ involvement happened. That means because the nerve are interconnected with those interneurons, if patient have, for example, adenomyosis and have uterus nerve sending hypersensitive signal to the spine, then guess what? This patient also going to have bladder symptom and urgency. That's why it's so common to see on patients with adenomyosis or endometriosis to see also urinary symptom or bowel-related symptom. So again, this also review this different mechanism of convergence, which we talked about. The other one that I didn't say here is sympathetic efferent coupling. That means normally sympathetic nerve and efferent sensory nerve are not connected, even though they're traveling next to each other. But once the hypersensitization happened, the coupling also happened. That means sympathetic nerve also will cause pain in the pelvic area. And lastly, if the central sensitization is the beginning of bad stuff, because then if central sensitization remain untreated, this would lead to major issue like dysautonomia and POTS. If you notice, many of these patients with chronic pelvic pain, they also come and report low back pain, nausea, palpitation, excessive sweating, brain fog, orthostatic hypotension, and general fatigue. All of the above are a sign of centralization and more specifically dysautonomia. That means this patient been having this hypersensitization for many, many years. So now let's just see quickly, go back to that patient, and I'll show you a quick video of how we manage her. So this patient, as you can see, has active wound sitting on her hypogastric plexus, and it is a clear evidence of inflammation, as you can see. So dealing with endometriosis here is, we all talk about not to do fulgurization. Now you can understand why, because fulgurization of the lesion would only burn them and add more to the inflammation process and not removing the inflammation. The key is to get rid of inflammation off of this underlying nerve. You can see the hypogastric plexus immediately under that inflamed area, but clearly affected by it. And removing this active inflammation off of it would significantly improve their symptom. Actually, with the help of one of our residents, which she's gone now, we're actually trying to publish our data, which was IRB approved, and the study is finished, and approximately 100 patients that they have this condition done, and we clearly showed that after the surgery and removal of this active inflammation, the pelvic floor dysfunction significantly reduced. For example, the Nocturia was reduced by more than 50%. Or let me go to the next slide. Okay, and on many of these patients, especially this patient, as you remember, she also had referral pain and pain into the perineal area, and she was suspected to have pudendal pain as well. And you can see by reaching to the obturator internus muscle, there is a defect in the herniation of fat, which are usually these are inflamed adipose tissue traveling into the Alcock canal. And you can see the defect on the arcus tendinous fascia next to the obturator internus muscle. On the right side, on above, you see that's in obturator internus muscle. And what I'm pulling medially is the fascia of obturator internus muscle. And as you can see, by digging in, we can see the pudendal nerve traveling deep inside the Alcock canal there. You can see the blue one, that's the vein and internal pudendal nerve. And this is the ischial spine and sacrospinous ligament right there. Okay, so for patient with chronic pelvic pain, you want to have a full evaluation of all nerve to make sure they are clear. Now we can understand why a patient with painful menstruation often has urinary urgency, frequency, and constipation, IBS, and so on and so forth. The elephant in the dark pelvic room is, I would call it a small fiber polyneuropathy in pelvic area. The small fiber polyneuropathy is not a term I invented. It exists and is referred to peripheral neuropathy involving mostly the extremity. But if there is peripheral neuropathy on other organ, why we cannot have peripheral neuropathy in the pelvic area? All of the nerve I show you are actually peripheral nerve. What's the cause of SFPN in the pelvis? The main cause is inflammation, and inflammation. Now, but there is also other cause. So it could be, for example, entrapment, prolonged tension and pulling in the case of, for example, pelvic organ prolapse, the mechanical pressure of big tumor or pregnancy, like fibroid tumor. Diabetic neuropathy could cause also polyneuropathy in the pelvis area, as it can cause neuropathy everywhere else. And other could be Lyme disease, vitamin B deficiency, chemotherapy, lead toxicity, and medication. But as I said, the inflammation is the big one here. And why and what is the main cause of inflammation in the pelvis is the big guys are infection, endometriosis, underlying inflammatory disease like IBD, colitis, diverticulitis, appendicitis. In addition, altered immune system or underlying autoimmune disease or stress. and also this mast cell activation syndrome, which is kind of new thing, and it's very fascinating when you read about it. It also could be the cause of the inflammation in the pelvic area. Prior surgery, like especially prior C-section and reconstructive surgery, since we use a lot of suture attaching it near the uterosacral ligament, and you can see the traveling of the nerve very close to the uterosacral ligament there, which could be entrapped during a stitch placement there. And prior intrapelvic hemorrhage could also lead to inflammation there. How do you manage the pelvic? How do I manage the patient with PFD? So again, the key here is the detailed clinical history. Detailed menstrual history is extremely important. Believe it or not, I get most of my endometriosis patients coming to me not for pelvic pain. They come to me for urinary urgency, nocturia, and difficulty emptying their bladder. They feel like they can't empty the bladder, and the matter of fact is this sense of urgency is a fake sense. It's not a real sense. Therefore, this poor patient goes in the bathroom and sit for an hour to empty their bladder, but there is nothing in the bladder to empty. There is all fake message sending to the brain because of those hyperexcited nerves. So detailed menstrual. So when patient come with recurrent UTI to my office, first thing I said is first question is, how is your menstrual history? Do you have pain? And often their answer is yes, they have painful period and so on and so forth. So ask about other organs in the pelvis exam. So if you are a gynecologist, always ask about bladder symptom, always ask about bowel symptom, and so on and so forth. That's very important. Always ask, especially about the topic that the patient are often embarrassed or avoidant to talk about. Sex and fecal accident are the big one, and even some patients avoid talk about urinary incontinence as well. So those are the questions you should ask and not wait for the patient to bring it up. Obtain obstetrical detail history is very important to find out patient have a forceps delivery, baby's weight, and type of laceration. Physical exam is very important. In addition to have a routine pelvic exam, which usually we are trained to evaluate the size of the uterus, the tenderness, presence of cervical motion tenderness, and discharge are all very important, but also transvaginal evaluation of inferior hypogastric plexus, the nerve that I show you, is very possible. We are actually lucky we are allowed and we are expert on how to do vaginal exam, because if you, it's just gonna take 10 minutes if I tell you to how to reach the hypogastric plexus transvaginally and touch them and examine them. Same thing if you touch the ischial spine, just cephalad to that, you can feel the pudendal nerve as well. And examining them, if there is a tenderness, is not normal. We usually refer this tenderness when we touch side of the vagina as a muscle pain, but those are indeed the nerve pain, those inflammation I showed you. So pelvic focused neurological exam would be also extremely important to see if there is obturator nerve is involved, if it's a pudendal nerve is involved, and also evaluate the degree of prolapse. By completing the HMP, you should be able to identify the cause of small fiber pelvic polyneuropathy. So after the HMP, so you have to decide this is inflammatory or non-inflammatory. If it's inflammatory, I told you what is the category of inflammatory is infection, endometriosis, and so on and so forth. If it's non-inflammatory, you look for entrapment, prolonged tension and pulling, mechanical pressure, diabetes, and Lyme disease, vitamin B, so for B deficiency, and you can do appropriate testing regarding to that. So if it's an infection, obviously, if you suspect infection, there's nothing wrong to try a course of antibiotic, but those antibiotics should be a target for soft tissue treatment, and the length of treatment usually should be at least 10 to 14 days if you suspect the infection causing the inflammation. Endometriosis, obviously the hormonal and laparoscopic excision would be the way to go. For underlying inflammatory disease like IBD and diverticulitis, you treat the underlying problem. For altered immune system and also for mast cell activation syndrome, if you are suspecting, you send it to allergist or immunologic workup. You can start. I do it myself, a lot of workup in the office, but there's nothing wrong to refer them to allergists. And in case of prior surgery, if you suspect prior surgery is the cause of her inflammation, then your patient may need to have a surgical exploration and lysis of adhesion and neurolysis. I will thank you. I just passed my time. I'm sorry if there is any question. I'm open to answer. And here's my email address. If anyone want to have conversation, you can email me, and I'll be happy to respond. Thank you.
Years, and for a patient who is diabetic for years and you suspect that the reason of her symptoms is the diabetic neuropathy at the level of the pelvis, typically those would be irreversible. How would you treat those?
The way is basically exactly how you manage the diabetes for any other polyneuropathy. That basically you're using the obvious first thing is to make sure the patient is sugar is controlled. You use medication like gabapentin and for diabetic patient, unfortunately, you can't go because these are underlying nerve issues. You cannot go surgically change those nerves. So you have to manage it with the combination of medication plus physical therapy. I really like actually radio frequency treatment for those which can be performed transvaginally for them. Which with the high energy setup, you can target those hypogastric nerve and make this hypersensitization to go away and modify that. But other than that, it's just basically gabapentin, using vitamin B and stuff like that. It's just no difference than any other. The only thing I would add is that radio frequency, or actually also you can use electromagnetic stimulation would also be helpful. Also for their overactive bladder, for them, usually beta-3 agonist would be very helpful, like medication like Gemtesa is very helpful.
Thank you. Thank you.
Thank you. Any other questions or comments for Dr. Shakiba?